And thank you very much for attending this short webinar on human factors, and for giving up an hour of your evening. It's very much appreciated. We've got people from the UK and indeed across the world, so many thanks. My name is Peter Brennan. I'm a maxillofacial surgeon based in Portsmouth, and I'm also an elected member of the College Council, and I have an interest in human factors and safety. We've got a diverse panel this evening, and I'd just like them to introduce themselves, and then we're going to have a presentation by Niall Downey, who's a cardiothoracic surgical trainee who then became an airline pilot, followed by Sadia, who's a human factors expert, and we have Ellie, who's a medical student who's had both good and bad experiences, both in outpatients and in the operating theatre. So Sadia, ladies first. Sadia, would you just like to come in and just introduce yourself, please?
Hi, I'm Sadia. I'm a healthcare human factors lecturer at Loughborough University. I'm also a operating department practitioner. I'm still clinical on the bank when I do get a minute. And I worked in resus for about 7 years, which I really enjoyed. Thank you for having me and welcome to the webinar.
No, thanks very much, Sadia. And just before we went live, I mean, we make as humans about 5 to 7 mistakes every single day, and in fact, there was a mistake with your name, wasn't there, as well? So that's now been corrected. So I think so. So thanks, and you're very welcome. Thanks for coming. Ellie, would you like to come in?
Yeah. Hi, I'm Ellie. I'm a 4th year medical student at the University of Bristol, and it just have an interest in human factors. I think it's very interesting, with patient safety. So yeah, thank you for having me.
No, thank you very much. And Ellie's actually written a couple of papers on briefings and culture, and you're an author of the new human factors chapter in Gray's Surgical Anatomy as well. So you're very welcome. And Niall, last but not least.
Thanks, Peter. My name is Niall Downey. I have a number of hats. My main hat, first of all, is I'm an airline captain with Aer Lingus. I fly A330s on our long-haul fleet. Previous to that, I used to be a cardiothoracic surgery registrar back in the 90s, but it's back when there wasn't enough SPR jobs, so I fell between the stools and jumped ship. I also teach our human factors approach from healthcare from aviation back into healthcare, so that takes up quite a bit of time. And last but not least, I'm an author now as well, because during COVID, when I volunteered back into the NHS, I was told you weren't short of doctors. Thanks for offering. So I went and wrote a book instead.
Yeah, brilliant, and very, very worth reading your book now as well, isn't it? Excellent, really enjoyed that. So what we're going to do, I think Niall has very kindly agreed to kick off, and is going to give us a very kind of brief whistle-stop tour of some of the human factors that we think are probably relevant. Then we're going to have a short little discussion, and then Sadia will then follow up talking about resilience, a little bit about systems processes as well, which I think will be really interesting. So Niall, if I can hand over to you, and if we can have Niall's slides up, please. Will it work?
Every faith in Ria.
Yeah. No, I'm just starting to shake now. Look, there we are.
You see the slides down the sides. We should just advance on. We should reach them nicely.
Yeah. So that's us. We've already introduced ourselves. Yeah.
There we are.
Right, go. Right. Okay, thanks very much, Noel.
So one of the things that we're going to be talking about is where can this go wrong? What's plan B? Myself and Antonia had a practice run on this morning, and I couldn't actually control it properly from my side. So plan B already is that Ria's going to change the slides for me. So again, thanks for having me. If you just go to the next slide there, please, Ria. This will give us an idea of what the problem basically is in healthcare with human factors. There we have 2 totally different steroid injections. Now picture yourself at 4 o'clock in the morning in a side room, knackered tired on a 24-hour shift. You haven't had your breaks, you haven't had your dinner, and you're trying to pick the right steroid in a hurry, what's the chances of you picking the wrong one? I would guess fairly high. If you look at the next slide, another example, I was a cardiothoracic surgeon, so we would have patients go into renal failure post-op, so we would have them on dialysis on the intensive care unit. One of the things we had to be very careful of keeping under control was their potassium levels. If it went too high, they would arrest on us. So here we have 2 bags of renal dialysis fluid, and the one on the left, we believe, has twice as much potassium as the one on the right. Now again, picture yourself in a side room at 4 in the morning and think what's your chances of lifting the wrong one. Pretty much guaranteed. Next example, I'll show you something similar. There's endless examples of these, unfortunately, in healthcare. So if you just go to the next slide there, yeah. This is one from a hospital I'm working in at the minute. It's a cardiac catheterization lab. So they have to heparinize the patients before they put the cardiac catheter into the artery and feed it up into the heart so that it doesn't have any clots forming on it, which can then shoot off. They normally use 5,000 units per mil. And that means for the 10,000 units that they need 2 mils of heparin. This week, the pharmacy department didn't have their normal one, so sent this one up instead. Now again, where can this go wrong? They're used to seeing 5,000 units per mil. Most people, when you look at things, we tend to be in a hurry. We take shortcuts. That's how the world works. That's how we manage to achieve most of what we achieve. If you're expecting to see 5,000 units per mil, when I glance at that top corner, I see 5,000 units in brown, and I see per mil in green. So I'm going to see what I expect to see. I would suggest a better idea would be to scrap one of those dosages and just put one or the other, because I can count, I can work out how many mils I need for 10,000 units. And it almost caused problems. People almost got a fifth of the heparin dose they were meant to have this week. If you go to the next slide there, please, Ray. Again, when we have people post-op in intensive care, they'd often be on various infusions. We have the people maybe on 3 or 4 at a time, wouldn't be unheard of. If you're changing the infusion overnight, chances are you're changing maybe a couple of times. If you think when you're unlocking your phone, you don't actually think of the actual numbers to unlock it. You generally think of the muscle memory. You think of the pattern. So when you're changing the infusion a couple of times during the night, you're going to do the same. You're just going to type in the same flow rate using the pattern that you've been using your muscle memory. The problem with that is if you look at these 2 infusion pumps, which might be on the same drip stand, the one on the right has 1, 2, 3 across the top. The one on the left's got 7, 8, 9 across the top. So if you're using muscle memory, you're going to type in a totally different flow rate, which could possibly kill the patient. Okay, so that's the sort of environment you're working in. Basically, you can see that human factors hasn't got a look in. It's been designed by people who probably don't actually work on the shop floor at all. It's been designed in offices and labs, and often it's been designed to look nice. It hasn't taken the human into account at all, which is possibly why the adverse event rate is as high as it is. So if we go to the next slide, please, Ray. This is my current office. It's an Airbus A330. I've been flying with Aer Lingus now for 25 years. I've been doing, for the first 7 or 8 years, I did casualty registrar work as well. So I kept my hand in both camps for quite a while. And then basically just ran out of time and had to sort of cut the medical work. For the last 13 years, though, I've been dipping my toe back in by teaching our human factors approach back into healthcare. Now, some of you who've been about for a while will remember when CRM was introduced into healthcare about a decade ago. And it wasn't a success. And I think the reason it wasn't a success is that it was done basically as a transplant and was a bad tissue match who got rejected. But having worked in both industries, I think the underlying DNA is very compatible and that we can genetically engineer it in, which is what I've been trying to do instead. The principles are very transferable. Basically, if we can apply our aviation framework and then you guys flesh it out according to what you need in your own environment, I think it's very transferable and could make a huge difference. So that's my current office. If you go to the next slide, Ria, we'll see my previous office. As Peter said, I used to be a surgeon. I was a cardiothoracic surgery trainee in Belfast and in Dublin. Back then, the system was you had to get an SPR, specialist registrar job, to get a consultant training post. And there wasn't enough to go around. There was 3 SPRs in my unit. And there was 13 registrars, and 13 into 3 doesn't go. I ended up falling between the stools like quite a few other people, and the following week Aer Lingus had an ad in the paper, and I had no interest in aviation, unlike Peter. I had no background in it. I had no plans to become a pilot, but I needed a long-term career, and Aer Lingus offered me one, so I've been there for the last 25 years. So go to the next slide, please, Ria. So let's have a look at a few numbers. Myself and Peter differ slightly on the stats here. You can make an argument for either side, so it's not really a big deal, but here's figures going back about 50 years. Looking at the number of adverse events in healthcare. I say we've got half a century's worth of figures. We've got figures there from the Northern Hemisphere, Southern Hemisphere, first world countries. It's the same with third world countries, developing countries. Basically, the adverse event rate in every country is assessed as being anywhere between 5% and 10%. So that's of all inpatient admissions, between 5 and 10% have an adverse event. Now, an adverse event is basically something that goes wrong with the patient unrelated to what they actually come in with. So basically a mistake made by a staff member, human error. So next slide, please, Aria. So let's look at a few stats. This is Marty McCarry. He's a professor of public health in Johns Hopkins in Baltimore. He's also a professor of endocrine surgery over there. He's from Liverpool originally, but he's been in the States for a long time now. Marty wrote a paper back in 2016 looking at the adverse event rate in the States, and it was so controversial that none of the American journals would even publish it, so it ended up in the British Medical Journal instead. He showed, if you look at the stats, medical error was accounted as the third leading cause of death behind cancer and heart disease in the US. So we'll go to the next slide, Ria. We'll have a look at figures a bit closer to home. Here's figures from around about the same time. This is 2015 from the NHS. Look at the big green box, a number of adverse events between 8 and 12%. So say ballpark figures, we'll call it 10% of all admissions have an adverse event. If we move to the next one, please, Ray, bring this closer to home for me. I'm a fellow of the Irish College. I'm from the Royal College of Surgeons of Ireland. They published a study along with the Royal College of Physicians in Ireland, the HSE, which is our version of the NHS, and the Health Research Board back in 2016. It's the first time they'd looked at adverse events in Irish hospitals, and they found basically that the stats were broadly consistent with baseline studies in other countries. So basically, Ireland's not an outlier, the UK is not an outlier, everybody's got the same stats worldwide, and nobody's managed to crack this yet. If you go to the next slide, Ray, there's a few details on it. We pick out the important bits. So they found again 12% suffered an adverse event. So again, we'll call it 10% ballpark figures. And further on down, we can see 7% contributed to the patient's death, and over 70% of the events were considered preventable using basically aviation safety type human factors. Now, they repeated the study 5 years later and got the exact same stats. And funny enough, it's possibly because they didn't actually change any of the procedures that they were doing. They found that 70% were considered preventable, but they didn't actually get around to trying to prevent any of them. So if we go to the next slide there, we'll work out a few numbers. Just put in context, even if we stick with the Irish ones for a moment, we can then translate it into UK figures. This is an Airbus A320. We've got about 35 of these in Aer Lingus. We use them for flying around the UK and Europe. There's about 174 seats there. In the Irish Health Service, we've got 650,000 inpatient admissions per year. If 10% have an adverse event, that's about 65,000 adverse events in a year. If 7% of them it causes or contributes to their death, that's about 5,000 deaths per year. So that's about 100 per week. So for ballpark figures, in the Republic of Ireland, we're crashing one of these A320s every 10 days. And to bring it to UK figures, the UK population is about 10 times higher than the Republic of Ireland. So in the UK, we're crashing an A320 every day. So imagine if we crashed an A320 in Heathrow every day and it never made the news and it didn't have to go to the regulators. I think people will be asking questions. So basically, does healthcare have a problem? Yes, it does. It hasn't addressed human factors. Is that problem causing any sort of great consequences? We're crashing a plane every day. So yes, it does. So the third question then is, can we do anything about it? And I think, yes, we can by using our aviation safety human factors. So if we go to the next slide, please, Ray. Our big take home in aviation is that error is nothing to be ashamed of. So if you remember nothing else from tonight's hour, remember this: error is nothing to be ashamed of. I know when I work in healthcare, and from keeping an eye on the media, I think it hasn't changed that much. If you make a mistake in healthcare, it's name, blame, shame, retrain. In aviation, we expect to make mistakes, so we don't see that it's any big deal when we do. So if you go to the next slide, please, Arian. We'll see a few examples. No, I skipped on there. I'll just go back there to look at that one. If you can play that video first, please, Ria. This is the biggest security event in Ireland this century. This was the Barack Obama visit in 2011. Here he is in the Beast, leaving the American Embassy in Ballsbridge. And I don't know if you can hear the sound. It's not coming across on my side, but the Beast is bulletproof, it's bomb-proof, it's chemical weapons-proof, and they have a fridge in the boot where they actually carry the president's blood. So if he gets shot, they can take the blood to the hospital with him. One of my friends was the head of the police tobacco unit at that stage. They had checked all the sewers under Ballsbridge that week for any suspect devices. They had welded the manhole cover shut. They had a helicopter above the embassy for the whole time he was there. They had cancelled all police leave for the whole duration of the visit. And now here he is as an absolute sitting duck in the middle of the road in Ballsbridge because the car was so long it got beached on the ramp on the way out of the embassy. The car was there for 4 hours before they managed to get it moved. Now, by pure luck, again, one of the things we preach is the Plan B approach, which we're already using ourselves here. Turned out, by pure luck, Obama and Michelle were in the second car that day, so they were able to reverse back and go out a different exit, which is how they came in, which is why it didn't happen on the way in. Go to the next one, please, Ariel. Someone we all know and love, who can we always rely on to make mistakes. I'm not getting any sound on my side. I don't know if you are. Basically, this is Boris Johnson at the start of the Ukraine war about 2 years ago now in Westminster. And he just wanted to thank Vladimir Putin for his inspirational leadership so far. Vladimir Zelensky. So you always rely on Boris not to let us down. So basically, we can see that in security, entertainment, if you can count Boris as entertainment, politics, all sorts of levels, people make mistakes all the time. So why should the healthcare workers be embarrassed when they make mistakes? So if we go to the next slide, please, Ria. And we'll look at what do we do differently in aviation compared to healthcare. 3 big things. Basically, we have a framework approach. The first leg of the framework is culture. We've got what's called a just culture. So if I make a mistake tomorrow, I can put my hand up and report it, safe in the knowledge that it's actually drawn into international law. I can't be disciplined and I can't be dismissed as long as it's a genuine mistake. Now, it doesn't cover gross negligence and it doesn't cover malice. So it's not a get out of jail free card. But if I make a genuine mistake, I can put my hand up. Second thing then is, I know from healthcare, it tends to be about finger pointing. A lot of the stuff in healthcare is about finger pointing and being able to pin the blame on someone. So now we've now dealt with that. We can now move on and not really address the real issues. So it tends to be about who went wrong. In aviation, we look at what went wrong. So if I make a mistake tomorrow, Aer Lingus' mindset is basically, well, you've been flying for us for 25 years. It took you 25 years to make that mistake. So if you're a crap pilot, why did it take you so long to get that wrong? So we assume that something happened in the system. We dig into it and see, well, what went wrong today? What was different? The Swiss cheese model, and see, why did you make that mistake? We usually find the tripwire that we fell over, and then we try and engineer out of the system, and ideally we try and engineer in a safety net to protect us. So basically another layer of the cheese. And lastly, the third leg of the stool is the crew resource management. That's our underlying operating system. So it's about avoid, trap, mitigate. We assume we're going to make mistakes, so we try and look out for them in the first place. We try and avoid them. We try and trap the ones that get through, and we try and mitigate the ones that get further down the line before we either crash a plane or crash a patient. So go to the next slide there, please, Ray. Basically, summarising that, we accept error as normal. Healthcare hasn't got to that stage yet. We look at the system and see what went wrong. We find where was the tripwire today. We engineered out and we engineer in a safety net to change that. And then lastly, the third leg of our framework, we train staff to manage error. So notice not to stop error happening at all. No matter how hard we work, there's going to be errors. So we need to learn how to manage them to avoid them turning into a major adverse event. So next slide, please, Ariel. So we talked about the Swiss cheese model. This was James Reason from the University of Manchester. When we dig into the system, we always basically healthcare's problem is that they dig into the system. Who made the mistake? Peter Brennan did. Peter Brennan is a crap surgeon. Peter needs to work harder. Problem solved. Let's move on. Whereas in aviation, we look at what went wrong. We dig a wee bit deeper and say, well, why did Peter make that mistake that day? Peter had been up operating all night doing an emergency. Peter's registrar is off sick this week, so Peter's covering the registrar as well. The hospital is actually on fire at the minute, so there'd been a fire alarm going off in the background while he was trying to concentrate. So we usually find there was a whole series of other things that led to Peter making that mistake. So we then see, well, which of those can we address? And we try and plug all the holes in the cheese. And basically that's where the avoid, trap, mitigate comes in. The more layers of safety we have, the better our chance of actually trapping an error before it gets to the stage of killing the patient. And again, with us, we tend to have multiple layers of redundancy. That's why we have multiple computers and backup systems on the plane. So we expect to lose some, and we can continue on regardless with that. So for the next slide, please, Ariel. So basically, summarising, we've already discussed this. Where can this go wrong? I tried this presentation with Antonia earlier on, and we couldn't get it to work from my side. So what's plan B? Ria's very kindly stepped in and she's doing it all for me. So I've got the easier option here. So same in healthcare. If you're approaching a patient, even if you're communicating with a patient, we'll look at that in a second. 70% of errors happen in communications. So if we can address even communication on its own, we've already seen that 70% of, or 10% of patients have an adverse event. 70% of the adverse events are preventable. and 70% of them are due to communication. So we can catch half the adverse events by dealing just with communication alone. So whenever you're talking to a patient, when you pass on a message, are you sure they actually received the message you think you transmitted? So they might have heard something totally different, despite the fact you've given a very clear message. So what's plan B? See, from a communication point of view, we have closed loop communication. So we would then get the patient to respond to us and clarify from their point of view, what did you understand from that? So from the next slide there, please, Ray. The other thing as well is what's in it for me. I trained an intensive care network team last year. There was about 400 of them, so we did about 10 training sessions of about 40 each. One of the things that came up was medication errors, which is one of your biggest issues in healthcare. A nurse had given the wrong dose of a medication during a night shift. The management looked at it, did the root cause analysis, and of course, root cause analysis was that the nurse had made a mistake and hadn't read the dose properly, so it's the nurse's fault. So what was the solution? She now has to cross-check the dose with one of her colleagues before she can actually give it. So when you dug a wee bit deeper in the RD aviation angle, when I looked at it, I thought what was actually wrong is it's post-COVID, they've lost a lot of staff, they've a lot of agency staff now who don't work in the wards, so she was trying to mentor them. She was missing breaks. Basically, she was too busy. So how did we resolve the problem? We made her busier. So what's in it for me? Is that going to work? No, it didn't, funny enough. So whenever we do make changes, we need to involve the staff and bring the staff in. You guys generally know where the mistakes and the problems are, so you guys need to be part of the solution. So you need to help sort of work out the solution, not have it imposed on you. Next slide, please, Ray. So just briefly then, we'll just finish up with, we've already spoken about crew resource management, CRM. It can be broken down different ways. We tend to break it down to about 6 big headings, and we've already said that 70% of issues are due to communication. So communication should be dead easy. Basically, you've got a communicator, you've got the message, and you've got the receiver. So you just ask for what you want, and you get it back. So if we go to the next slide, we'll see an example of that, although I think the sound might not work. I don't know if anybody's hearing that, the sound. Well, basically, it's the two Ronnies. It's one of their most famous sketches. Ronnie Barker's come into a hardware shop. He's the communicator. He's got a message. He wants 4 candles. And Ronnie Corbett's the receiver, and he's just gone behind the counter, and he's going to produce 4 candles. And Ronnie Barker says, no, 4 candles. And so, well, there you are, 4 candles. So it turns out what he actually wants is 4 candles, handles for his garden fork. So basically, we took what we thought was a very straightforward message, very simple, passed on perfectly clearly, but the receiver heard something totally different. So whenever you're talking to a patient and explaining something, first of all, on a good day, people only take in about 30% of a message. On a bad day, when you're a patient, you're going to take in less. So despite the fact you've given them a very clear message, they might have heard something totally different. So what's plan B? Again, closed loop. Bring them into the conversation, get them to explain back their side, what they're expecting, what their fears are, and work out, have they actually worked out or understood what I've told them? So go to the next slide there, please, Ray. We're nearly done. And this is just to compare my world with your world. We've seen your medication issues, the way your stuff's labelled, the way we can genuinely make mistakes. Here's my world. This is a $240 million airplane. Now, any takers as to what that lever does? So that's sticking out of the front of my dashboard, right in front of my face, just where my hand will reach automatically. If I'm coming into land and I want my wheels down, I grab a hold of the lever with wheels on it and I put it down. That's as simplistic as we make it. We assume pilots are thick as pig shit, and everything's designed around that. We assume we're going to make mistakes, and the human factors approach is we try and make it as easy as possible to do the right thing. For me, that's what human factors is, make it as easy as possible to do the right thing. So the final slide there, Ria, that's me wrapped up. So that'll give you a rough outline of how aviation sees human factors. I think me and Peter agree on most of that, and we've already collaborated on work trying to bring the aviation approach into healthcare. And I'm sure he's going to elaborate on that for me now.
Yeah. Well, thanks very much, Neil. And we could spend hours and hours, obviously, talking about this. And in fact, Niall and I spoke at the Society of Cardiothoracic Surgeons. When was it? A couple of years ago, back in Belfast. And that actually brings in, team working and how teams interact with each other and the stress of the operating theatre. And we staged, didn't we? We staged an argument on the stage about the incidence of error, and the paper that I use is the one quoted there in the BMJ of 337,000. And Niall and I had an argument on the stage, and it got progressively more heated, didn't it? And
I stormed off stage in a huff.
yeah. And the audience is about 350, 400 cardiothoracic surgeons, trainees, medical students, and so on. They were absolutely shocked and horrified. And then Noel came back in, and we said, and we just stopped and said, how does that make you feel? And they were just, I think someone shouted out, well, it's a disgrace. Well, it's like, no, that was actually planned, and this is actually what happens in your theatre. Occasionally, and team working and toxicities and things, which is a real barrier to human factor, to safe communication, empowering the team to be able to speak up, and if they have any concerns, valuing the team. So Ellie, I'm just going to bring you in as a medical student, and can you just give us that example of what happened to you in the operating theatre and how that made you feel?
Yeah. So I'd like to say, first of all, I've had lots of fantastic experiences in theatre, but I had one occasion where just to start, like, sort of wasn't introduced, was kind of ignored throughout the procedure, which is, as a student, you do get used to that feeling. And then there was an instant where I got a swab thrown at me, which was quite, it made me feel quite sort of upset, and it sort of belittles you quite a lot, and you feel like in that moment I was like, I just wanted to leave the theatre, and obviously was not then going to ask any questions or want to get involved at all. So yeah, I think it was the whole sort of the whole thing from the beginning being ignored, and then that almost act. So yeah.
Yeah. So I guess the question is, and Niall talked about hierarchy a little bit as well. Actually, would you feel if that surgeon was going to operate on the wrong side, for example, or was doing something that you thought was unsafe, would you feel able to speak out and to challenge that surgeon?
No, definitely not. And I think probably not even from the beginning, being ignored sort of at the beginning of the procedure, definitely not. And then, with the swab thrown at me, absolutely not.
Yeah. No, really, really sorry to hear that. So for most of us on this webinar this evening, what we want is the practical elements of human factors, how it relates to me and you, what we can do to make it safer, the effective communication. Now you touched upon that, having the eyes and ears around you from the rest of the team, so empowering the most junior person in that operating theatre, from a healthcare support worker to a medical student, right up to the most senior person. They're your eyes and ears. They're looking out for you, and you're looking out for them, and you're building situational awareness, as we call it. I think what we're going to do is we're going to go on now, and Sadia is going to give a talk a little bit about systems, which is a really important part of human factors, and just give us an oversight on that, and then we should have 15-20 minutes to have some discussion at the end. So if you've got some questions, please hold them, and we'll put those in the chat after Sadia's talk. Thank you very much. So can we move on with the slides then for Sadia, please? The next slide, please.
Yeah. We did practice this earlier, and of course, okay. Ooh. Are we able to see that? Sorry, I can't see anyone.
Yeah, we can see that. Yeah.
I'll share it again. Okie dokes. Hi again. So I will be talking a little bit about systems and resilience on the front line, and in this case, in surgery. A quick overview. I was going to start off about myself, a little about myself. I do want to speak a little bit about COVID and how it brought the term resilience onto the forefront for many of us, what resilience is in healthcare, and how human factors can be the resilient solution. I will touch upon a few theories which Niall has kindly already covered, and how they're relevant to resilience in surgery. And then, of course, I will finish off with team working and safety in surgery, and how it all integrates and intertwines with systems thinking and resilience. So I was going to do a long introduction, but just a brief background into how I got into human factors. So I've always been interested in human behavior and interactions. So I went off and did an undergrad in psychology and sociology. Absolutely loved psychology, especially the research component. I also wanted to give back to the NHS, and this is because I'm very grateful to the NHS, and that's because I have psoriasis. And as a child and a teenager, I spent a lot of time in the NHS, and I think nurses, doctors, healthcare assistants, medical students, everybody's just fantastic. So I decided to train to become an operating department practitioner. And then once I did that, I was working in orthopedic theatres. Whilst I was a student, the WHO surgical safety checklist was introduced. And that's when I thought, oh, this is good, because now the consultant actually knows my name, which never actually happened before. So yeah, I did think the surgical safety checklist did empower everybody in theatres. It is a bit of a shame. Listening to Ellie's story. I then moved to resus for the adrenaline, worked in a mental health trust for a bit. I did a study called Respond at the University of Oxford, which I will talk about later. And I'm currently working at Loughborough University. So I do want to yes, my animations are not working properly, but that's okay. So human factors, I always start with definitions. So human factors is a scientific discipline that uses theory, principles, data, and methods to enhance human well-being and systems performance. Now, when we mean human well-being, we mean both patients and staff, and families and carers, because we like having everybody involved. And in terms of systems performance, we mean the systems that you work in, the tasks, the processes, your day-to-day tasks that you carry out as surgeons or healthcare professionals. How can we improve that using human factors? So COVID-19 was very important for everybody. It changed for everyone. I was still working in research, and I still remember we didn't know it was airborne. So I was stressed. It was during the PhD time as well. And we were learning and we were looking at what Italy was doing, and what we kind of saw in terms of the mental state, and what we're learning now is that the mental state of the Italian population was really affected. And this was because the whole country was going through grief and mourning, because many people died. Many staff had mental disorder concerns related to anxiety, depression, and distress. And previous studies have actually suggested that pandemics do leave a long-term effect on mental health. Now, in the United Kingdom, Boris Johnson seems to be popular today. We did go into lockdown. Just under 230,000 people died, and there were more than 1.1 million people in hospital needing care for COVID. We all saw the strain that it took on everyone. It was emotionally, mentally, and physically demanding. We had loads of changes. We had positive things, but most of all, there was an extra strain put on specific services. So there was an increase in elective surgery by 25%. There was a higher workload, and there wasn't enough staff, and people were getting sick. In terms of surgeons, the Royal College of Surgeons, of course, did publish some guidance. There was guidance from the Chartered Institute. There was guidance to support surgeons, but I think the mental health was really affected, and it was because there was always issues with personal protective equipment. There was grief going on in terms of family members. I've got a lot of friends who are registrars, and they would be working continuous nights because their colleagues were sick. And there was always that fear of an infection. So this is what led to that kind of those kind of mental health problems. It was also the stress and anxiety and the symptoms, which is actually referred to as PTSD now. was affected in nurses, it was affected in healthcare assistants, it was affected across the whole diverse range of healthcare professionals. Now, if you look at what resilience actually is, now, I know that when I've got my clinical hat on, if somebody talks about resilience, or, I used to coordinate research, and I, my, everything, safety was at my forefront of everything, but it wasn't my personal or psychological resilience that got me through that. It was the number of staff that I had. It was the skills of the staff that I had. It was whether I had all my equipment, whether I had, whether my rapid intubation trolley was set up. So resilience is actually the ability to be happy, successful, again, after something difficult or bad has happened. Now, COVID was very, very heavy for everyone. Just recently, one of my colleagues put up a post on stating that one of our other colleagues had passed away 2 years ago. So it is still quite raw. So we have to establish that psychological resilience is different from what people talk about in human factors and in healthcare. With psychological resilience, yes, it safeguards against burnout and mental health challenges, and it must be the number one priority. But it's not the responsibility of staff to build up this psychological resilience when you've been through a global pandemic. And that is a really important message that human factors, systems thinking, and resilience engineering tries to hone in on. So I will introduce resilience engineering. It's based on trying to make things go, preventing things from going wrong, but also ensuring that things go right. So we're looking at things that go right. So, for example, in the NHS, I used to work as a part of the patient safety team, and we have far more successes. So we have effective discharges than we do have incidences. So, there's been far more full patient care delivered in resus. They've gone to the ward or to ITU, then we have had incidences. And that's because we want normal outcomes. We want to focus on the positives, the right things. And when we say the positives, it's the adaptations that frontline staff make. Because essentially, the more likely that something goes right, the less likely it is to go wrong. So with resilience engineering, we look at what you do, the adaptations you make, and we see how they work in the overall system. And essentially what we do is we use systems models. So for example, we use SEEPs. Many of you might have heard of the Systems Engineering Initiative for Patient Safety. And this model essentially breaks down tools, technology, organizations, and person, which is in the center. Again, that is patients and staff, just to show you how complicated delivering healthcare is. We've been through a pandemic, things are tough, and we just need to kind of realize that resilience in healthcare is about redesigning your work system to make the way you work easier, safer, and effective. Now, this isn't a very safe example, but it's an example nonetheless. I'm very bad at DIY, so when I am doing DIY, if I'm trying to unscrew something and I can't find the correct screwdriver, I have guiltily used a knife. That's an effective yet dangerous adaptation. Please do not do this. However, that's an adaptation. So in healthcare, for example, in resus, many of you have heard of two handovers. So the paramedics will give a standard ABCD handover, and then a few minutes later, they'll come back and say, well, actually, I'm concerned about the patient's eating, or, there might be more. They always have a second handover. So that's an adaptation that's effective. I'm going to touch on some resilient theories just to kind of hone in on the fact that resilience is based on systems and not on you as healthcare professionals or surgeons or registrars or medical students. So there is a view of safety in resilience engineering where safety one is where we focus on what goes wrong. So it's reactive. We respond when something happens. So when somebody makes a drug error, which I used to make during my time in resus, unfortunately, what would happen? We would be banned from administering any drugs. So that would put a toll on the rest of the team, which would cause a negative culture where, like, you've let the team down. And then for further kind of, it was the reactive response, which was, you can't actually do any bank. So we'll financially suffer if we made a drug error. which does cause a lot of negative culture. Accidents are caused by failures, and in safety 1, the purpose of investigation is to identify the causes. Whereas safety 2 is looking at what goes right, what frontline workers do as effective adaptations. Humans are seen as a resource, and you're necessary for system flexibility and resilience. And the purpose of investigation is to understand how things usually go right as a basis for explaining how things can occasionally go wrong. Now, this is a theory that I've spent many years on working with, and it is quite a theory that I do resonate with. So when I was clinical, I did get told off they'd say, Sadia, you're not following policy. And oftentimes I'd say, yes, absolutely, but the policy would be 33 pages wrong. And at 4 o'clock in the morning, looking on the intranet when my login isn't working, I would think, what do I need to do? Do I need to cannulate this patient, do the ECG, get everything done, or shall I look for a policy? So then I spent probably 8 years, including my PhD, working on work as imagined versus work as done. So as Neil said earlier, you are the experts. People on the front line know what happens on the front line. Now, with work as imagined and work as done, it's separated by the work as imagined, work as done paradigm, which is separated by time and space. So as you can see, you've got the regulators and the managers in work as imagined. So this is what managers and designers and seniors think should happen on the front line, whereas work as done is what actually happens on the sharp end. So it's where you carry out those emergency procedures, and it's also separated by years, because it takes years to write a policy, months to get it reviewed and then approved, and then minutes to carry out the actions. However, I've written a policy or a few policies, and I know how long it takes. Now, in that time, we could have a pandemic, so practice will change again. So it really does we really need to understand the implementation gap. There is the difference between work as imagined, policy, and practice. And we do often use workarounds to fill in those gaps. So in terms of resilience engineering in surgery, work has started. So there have been qualitative and quantitative studies work together where they've mapped out how the preoperative and perioperative phase all work together, and they use a systems perspective. In this paper, they've also used work as imagined versus work as done. So it's a multifaceted approach to enhancing surgical practice. Finally, I'm just going to touch on understanding ways to improve patient safety and team working. So the illustration at the back is SEEPs and anesthetics. So what I've done, I've literally just mapped out all the tools and technology, the tasks, the people, the internal and external environments. And I've included people like the technicians, the medical reps, the students in the person, because all of these things are all occurring. We're interacting with new technology, internal environments, medical reps, students, while trying to deliver the safest and most effective care. So there's a lot happening in theatres, in surgical systems. So in terms of complexities of theatres, I still do work in theatres. And what I found that there are always multidisciplinary teams, even the anaesthetic, scrub and recovery team, although we're all working together, we have different skills. There's different equipment and technology. Plastics and eye lifts are so different compared to orthopedics. There are students, and students are very important. And that's because they are the future of the NHS, of the future of healthcare. So I do suggest that they are treated with respect and the WHO checklist is used. There is also a different level of competencies. So, you know, I might be confident in anesthetics rather than recovery. So we need to kind of have that overview too. There are also ways of measuring patient safety in theatres, and it's called the NOTEC system. I'm just going to quickly go over the Respond project.
We're going to have to wrap it up very soon, Sadie, because we need some time for questions and things. So I don't know if you can just finish in the next minute or so, please.
Yes, absolutely. So the Respond project combined systems thinking, resilience engineering, and we came up with 4 interventions which are based on reducing failure to rescue rates. There are other studies, such as anesthetic room studies, where we've used human factors, systems thinkings, and methods to enhance anesthetic practice. And essentially, the take-home message is resilience in healthcare is a systems issue, not a person issue. COVID-19 was the wake-up call for what resilience actually is, and we're just trying to make your work system easier, safer, and effective. Thank you very much.
No, thank you very much indeed, Teddy. And it's I mean, two diverse talks really, sort of showing the huge scope really of human factors. I mean, it's an enormous subject, isn't it? But I think for me, the clue's in the title, isn't it? It's what you said, Niall. It's that we're human. We make errors regularly. It's minimising error as best we can, and changing culture. And Colette, you've put a question in the chat there, recommendation for helping change culture to accept errors, nothing to be ashamed of. That's a difficult one. I think yes, you're absolutely right. And I think for effective human factors integration, I think you'd agree, Niall and Sadie, you need a top-down approach as well as a bottom-up approach coming from Ellie, coming from students, and you somehow equilibrate somewhere in the middle. What do you think? What do you think, panel?
Colette's question, I think, sort of cut straight to the chase of what the whole problem is.
Yeah.
Unfortunately, we have no quick answer for. As you say, though, that bit's going to have to come from top down. Until senior management accept that their staff are going to make mistakes and stand behind them and don't scapegoat them and turn them into whistleblowers. Until that happens, nothing's going to change, basically. We need someone at the top to sort of stick their head over the parapet and say, right, well, I'm going to stand behind someone who's made a mess of something in my trust or my hospital. And then treat them as being like the most valuable sort of player on the team that day, as opposed to the problem on the team. Basically, if you're the chief executive, you've a better chance of putting your hand up without it being shot off than the more junior staff have. So we need someone who basically is going to have the nerve to do that. Now, I'm working with a big private hospital group in Ireland at the minute, and that's exactly what's happened. The executive got in touch and said, we've looked at a lot of the human factor stuff. We agree this is where we need to go, and we want you to implement it across the whole network. Now, we're in the process of that at the minute. Now, once we get our first big event, we can find out then if they're going to walk the walk, as well as talk the talk. But I'd be optimistic, and I find then once one hospital does it, everybody else will want it as well. So we basically need someone to get the ball rolling, and I think it'll start falling into place beyond that. But unfortunately, Colette, I can't see that happening very quickly in the NHS.
So I think I can say that the UK regulator, the General Medical Council, now does recognise the importance of human factors, and indeed it's one of the generic professional capabilities. And I've published with the medical director of the GMC, Colin Melville, around fatigue and a few other things. So the regulator does recognise that. Ellie, can I just ask you, do you have any human factors training or education at uni?
Interestingly, in our interview, we got asked about like human factors, and there was like a picture of a plane. But no, we have a little bit on like teamwork and a little bit on error. But no, it's not really very part of the curriculum.
Sadia, what do you think?
Thank you. Absolutely. So, in a perfect world, having the concept of respectful challenge would be great. So I worked at a trust in Birmingham, and we had a massive poster in recess saying we encourage respectful challenge. So when I was working in A&E, I would feel comfortable enough to go to a consultant and say, look, I don't agree with that decision, and we will do it respectfully, so not in front of people, not in front of the patient. But what I've seen is that that's not possible. There is always a hierarchy, and people often say we do need a hierarchy, especially in surgery. But as Neil has said, we need a top-down approach. Ideally, I would like it to be a bottom-up and top-down approach, but I don't think we're there yet. We don't have that voice for your band 5 nurses, your band 6 nurses, your junior doctors. And I think that will take a few years of having human factors practitioners, having more human factors in curriculums, medical curriculums, nursing, ODP curriculums. I think we're a few years away, but we will get there eventually to have a bottom-up and top-up approach.
Yeah, and I guess that sort of partially answers Victoria's question about concepts of resilience and support offered by trust, focusing on individuals coping with stress, but resilience is not infinite and will fail if our environment, staffing gaps, whatever, continues to deteriorate. What approaches do trust colleges, associations take to address that? Again, really difficult question to answer. Sadia, I don't know if you want to say anything about that.
So I'm just, you know.
It's in the actually. Could you put the questions in the Q&A rather than the messages? And again, that was just purely because I just clicked on messages. Otherwise, then we would have missed that. You see, so please, can you put any questions in the Q&A?
So I've just, thank you, Victoria, for your question. It's very interesting because I try to think of it as an academic/expert and as a clinician. So when I have worked in private and NHS institutions, there's always support cafes, talking cafes. I think trusts are trying to do their best for psychological resilience, but what they're not doing is saying, the support that we're providing you is for work-related stress, the pandemic, and even things like social events. They say they help, but in terms of trust, I think the education in terms of resilient systems needs to be highlighted. I think the term human factors in the NHS is quite blurred. And what we need to do is say human factors is a science. It helps with systems, which will help with resilience because we'll have the right tools, we'll have the right people to support us in our day-to-day tasks. I hope that answers your question. And I understand that personal resilience is not infinite. I think working together, learning from each other, perhaps learning from other disciplines, aviation, pilots, air stewardess need resilience. Perhaps we need to learn from other organisations, other disciplines, but I don't think the NHS has quite identified systems resilience and personal resilience, and that's where the problem lies because it's quite blamey. Saying, yeah.
I mean that's another thing, isn't it? About us all looking out for each other. At the team briefing, which I certainly do, and I often get students actually to lead the briefing as well, which empowers them. They come in, they go away thinking, wow, what an amazing day they've had before it's even started. And please do look out for me. If we're doing a really long, complex operation, we will set a clock at about 3 hours, and if you're concentrating, the staff nurse, the anaesthetist, whoever it is, will call the time, and as long as it's safe to do so, we then stop operating, we down tools, we go away, we have a cup of tea or coffee, have something to eat, and then we come back, and you actually catch that time up as well. So just the power of teamwork and things is really critical. David Parry's put in the chat about that human factors is not in most curricula at the moment, which is obviously a concern, but especially as the GMC says that it should be. I'm going to put, time is actually running out. I'm going to put in the messages a link to the Civil Aviation Authority Human Factors Handbook. Now, I think, Niall, you would agree with me that we shouldn't compare aviation to healthcare or surgery. The two are totally different. But you can certainly learn lessons from other so-called high reliability organisations, HROs. And this is a free to download, I'm just looking for it now, a free to download resource written by a chap called Steve Jarvis, who's the Civil Aviation Authority expert advisor. Steve and I have written a course for the RCS about human factors. It's an online course, and we're currently writing a face-to-face course that should be available soon. So please download that and have a look if you're interested. And I think now probably if you take out the aviation examples, there's lots of thing about communication, threat area management, as you mentioned, resilience, all sorts of things in there. So please do download that. Well worth the read. Free to download. Emma, do you think there's something like, oh gosh, it's just jumped off there, something like a short course? And now, oh, here we are. Do you think something like a mandatory short training course in this domain could stir interest and awareness? Yes, I think the answer is to that. I mean, most definitely. As I say, we've written a short online course for the RCS, which is available. I don't have the link for that, but that's certainly generated a lot of interest already. If we think, so Richard, if we think about high versus low performing teams, do the speakers think that there are differences maybe indicative of total system processes that may be entirely different experiences and functioning, where care, maturity, trust and responsibility are treated in entirely different ways? What practical interventions would the speakers suggest to identify, understand and improve those problematic indicators to improve team working? Really long question. I don't know if we've got about 2 minutes left actually, so I don't know, team, if you want to try and answer that. Niall, final thoughts from you. I'll go across the panel.
I suppose final thoughts. A lot of people have asked again, how do we actually get the concept across? As we've already discussed, management need to sort of take the bull by the horns. You've done a lot from the top end, from yourself and from the college. I'm starting to get some buy-in in Ireland now as well, that people are starting to take more interest. Sadie is right, we need a top-down and a bottom-up approach. Unfortunately, we need the top-down first, or else the people at the bottom aren't prepared to put their hand up, and with good reason. Whistleblowers get their hands blown off. We've seen that repeatedly. But I think that we talk about evidence-based practice. All the evidence I've seen is that what you're doing at the minute is not working. So I think we need to try something different. And I think I've shown some of the evidence there, that in aviation, our evidence seems to be, our system seems to be, it's not perfect either, it's not Disneyland, but it's better than yours, and I think it's worth trying.
Yeah. Thanks very much, Niall. Ellie, any final thoughts from you then about medical student and what you'd like to see changed?
Yeah, I think just being like welcomed and introduced and just feeling a part of the team has such a massive impact on your experience in theatre or wherever it is, and like how well you learn. So yeah, just that as just being introduced honestly has such an impact. So yeah, that's what I could say.
Yeah, so thanks. So everyone, please listening in on this call, please empower your team, value your team, respect your team. So respect is earned. You know, if you give respect to anyone, then you will get respect back. Really important. Sadia, last thoughts from you.
Yeah, so in terms of systems am I answering the question, Peter?
Well, we've got about a minute left, so answer the question, whatever you'd like to do. Yeah,
so
if you can.
In terms of the question, there's some research being done at Oxford with the Respond team, and they use the concept of mil sports. They looked at military teams and sporting teams, and one of the interventions that we took away was away days. So we take staff away. It was a lot of work, and it was a form of team strengthening, enhancing culture. So things like that could possibly happen, but as I said, they do require a lot of work. I think that's my final thoughts. Thank you for having me.
No, thank you very much. And Emma asked us to email the Human Factors course. Again, this is multitasking. I'm trying to chair the session. I can't look it up, but you know, you've got the internet, so please do look that up. So I'd just like to once again thank everyone for attending. Thank you for giving up your time. I hope it was useful. Certainly we can do more of these events and things, and you know, again, just thank you so much for coming. And that's exactly 7:00, so we're going to end now, because with Human Factors, people want to go away, they want to spend time with the family, they want to have something to eat and drink and things. So can I just thank Niall, Ellie and Sadia so much for your attendance and for coming, and also I'd like to thank the back team, so Antonia, Ria and Sean Healy. Thank you so much for all the work that you've done. I don't know if you can put your cameras on, and Phoebe as well, if you can, and if you can't, not to worry, but thank you so much to everyone, and I wish you a very nice evening. Thanks very much for attending. All the best.